Hello, everyone. My name is Samuel Kennedy,
And I'm Dipen Mehta.
and today we're going to dive into the factors influencing the increased incidence and mortality of prostate cancer in Black men in the United States.
So let's start out with the question of what exactly is prostate cancer. Now, to understand that, we need to understand what the prostate is. Now, the prostate is a uniquely male reproductive gland that its main job is to produce seminal fluid to protect and nourish sperm. It also has some other jobs, though. One of them is to regulate androgen metabolism and overall male hormone regulation. It also controls urine output and seminal release. Now, as you can see in this diagram on the top right, this is the prostate gland. It's a bulbar gland with several different pipes running through it, one of them being the urethra, through which the urine and other fluids like semen go through. There's also the seminal vesicles, which produce this seminal fluid, which feed into the prostate. And so the prostate sort of acts as a hub for all these different processes. So what is the pathophysiology of prostatic adenocarcinoma, also known as prostate cancer? Now, the prostate is a gland, and so it's going to have a very glandular structure. The cells are going to be arranged in these tubes, as you can see in this cross-section in the top left image. And it's going to be a very differentiated tissue. In cancer, though, it turns into this undifferentiated mass of malignant cells. And so these cells morph and they become malignant. The prostate gland is also supposed to produce zinc and citrate. Those are key markers that distinguish prostate tissue as prostate tissue. Cancer cells are usually devoid of both of these. Now, what are some risk factors for prostatic adenocarcinoma? One of the main risk factors is age. As you get older, you're more likely to have prostate cancer. The other is family history. And then race and genetics also play a role in prostate cancer. And we'll dive deeper into these last two factors in this presentation. When prostate cancer spreads, it most often metastasizes to the bones. This is just because the anatomy is set up so that the venous blood drainage of the prostate goes near the lumbar spine. And so that's usually where prostate cancer spreads to. So how is prostate cancer diagnosed? Screening is done by measuring the prostate-specific antigen in the blood of men. And so the PSA is a marker that sort of tells you how active the prostate is. However, other pathologies involving the prostate can also have elevated PSA, like BPH, UTI, and even riding your bicycle too much can physically irritate the prostate and elevate PSA, which is why we have several different diagnostic tests, one of them being the digital rectal exam. In this, the provider inserts their finger into the rectum to feel the posterior part of the prostate, as you can see in this diagram. The posterior part of the prostate is most often where prostate cancer develops, so this is convenient in the fact that the provider can easily feel for any tumors or abnormalities in this part of the prostate. However, the most definitive form of diagnostic tests is biopsy. And biopsy is done by taking two different samples of prostatic tissue, looking at it under the microscope, and seeing how undifferentiated or differentiated the cells are. Based on this sort of morphology, the pathologist will give each sample a score, which is then added up to finally get the Gleason score, which is the official diagnostic measure used by urologists and pathologists to diagnose prostate cancer. So along with the Gleason score and the PSA level, the oncologist or the uro-oncologist will use T&M staging to finally determine the staging of the cancer as a whole. T&M stands for tumor, lymph node, and metastases. And based on the size of the tumor and the extent of the tumor, the urologist will give it a T score. And as you can see, it can be T1, T2A, variety of different scores. Usually as the numbers go up, it's more severe. However, if there's any spread to a lymph node, it automatically bumps up the staging to a 4A level. And if there's any metastases, it bumps up the staging to a 4B level. So it turns out to be prostate cancer. What can we do about it? There's several different methods that we can use to treat or even surveil prostate cancer. As Dr. Terrace often would say, you are more likely to die with prostate cancer than of prostate cancer. And so monitoring is often a method that urologists use to look at the growth and progression of prostate cancer and intervene only when it's necessary. Watchful waiting, active surveillance, checking PSA levels frequently are methods that urologists use to keep track of prostate cancer growth. Hormonal therapy is also an option. Anything from androgen deprivation therapy to receptor antagonists to synthesis inhibitors, anything to disrupt the male hormone activity can also reduce the size of prostate cancer tumors. Focused therapies also exist. Focal ablative therapy and radiation therapy are ways to directly target the tumor. And if the tumor has spread to other parts of the body, chemo and immunotherapy are also used. The surgical intervention that's most often used is radical prostatectomy, where the prostate is completely removed surgically.
As my colleague Dipen mentioned earlier, there are several factors that go into the development of prostate cancer. And we're going to focus on one of those risk factors, race. And then so prostate cancer is actually the #1 cancer diagnosis and the second leading cause of death in Black men when it comes to cancers. In fact, Black men are twice as likely as white men to die of prostate cancer. And then so you have to wonder, why is this? So a recent article showed possible reasons for this disparity, such as genetic factors, things related to the genes and where people hail from, lifestyle factors such as diet, exercise, as well as factors like direct and indirect factors due to race. So let's talk about the genetics. So when it comes to developing prostate cancer, several genes have been identified in men with African ancestry. And of the different genetic risk variants of prostate cancer, those with an odds ratio greater than 1.1, meaning more likely, were more common in men with African ancestry. And some of these genes, in fact, have been found only in men with African ancestry. And then next, we'd have to consider access to care. And we all know the role that social determinants play when it comes to healthcare system and delivery of healthcare. And they also play an important role in the prostate cancer stage at diagnosis as well as mortality. And then there's different socioeconomic factors we want to consider. Things such as education level, income, which could affect, availability of resources. And then we have availability of neighborhood clinics. Do these people have a clinic they can go to get the screening for prostate cancer? And then transportation. Do they have to travel far to get the care they need? And then these factors of socioeconomic status are in fact correlated with race in the US. And we have a quote here which states that compared with whites, the risk of mortality in African American men with prostate cancer was not significantly different after adjusting for poverty, income, or composite socioeconomic variables. And then looking at this, we have to wonder if adjusting these factors makes the risk uncomparable, then they have to play a large role in why these disparities exist. And if you look at the chart on the right here, the income of the Black population is significantly lower than other races. That being said, with the adjustment, the risk of mortality was not that much different. And then next, we have to consider how prostate cancer develops slowly, as my colleague Dipen said. So being able to catch this disease at an early stage can lead to a better outcomes and being able to actively monitor the progression of disease. And without access to regular care, it can take longer for the cancer to not only be detected, which means it'd be found at later, less manageable stages. And then not only access to care has to be considered, but what about access to quality care? So in the healthcare field, there's been a history of mistreatment that contributes to mistrust about the quality of care received. Things such as the Tuskegee syphilis experiments in the 30s through the 70s, they affected how communities and populations trusted the care they were receiving from their providers, along with things such as long-standing medical myths, which were published in the medical journals in the past, such as higher pain thresholds and reduced risk of injury in Black patients, led to patients not feeling like they're receiving the same quality of care as they should be receiving compared to their white counterparts. And then these lead to the mistrust in the healthcare system and could ultimately be a barrier to receiving timely care.
Along with this, uh, a recent study showed that Black, Hispanic, American Indian, and Alaskan Native populations are less likely than other groups to have health insurance coverage. They're more likely to delay care due to costs and are subsequently more likely to incur medical debt. So there exist high financial barriers to accessing care. But when they do access this care, there are studies that show that the care itself is of lower quality. A 2023 assessment by the Federal Agency for Healthcare Research and Quality showed that Black patients received worse care than white patients on 52% of quality measures. This is a chart from another report that looks at state health disparities in 2024. And this chart displays health system performance scores based on stratified by each community and ethnicity. As you can see, the Black populations are represented by the green dots, and consistently across all 50 states, they score lower than many of the other counterparts, such as white and Asian. Now, these scores are calculated using a variety of different factors, including health outcomes, healthcare access, healthcare quality, and other, a total of 25 performance indicators were used to calculate this health performance score. So, continuing on the quality of care, among insured men who say results from 2011 to 2017, those men that were Black were less likely to undergo subsequent MRI compared to white men, which is usually a next step in the medical management of an elevated PSA with suspected prostate cancer. And these were insured men. So it seems like, and this is a quote by Dr. Ravenel, that for reasons that remain unclear, Black men who need high quality treatment may be choosing against these therapies, or that such treatments may not be offered to them to start with as aggressively as they are offered to non-Black patients. Now, several causes that we've identified and hypothesized might be causing this is conscious and unconscious decision-making bias on behalf of the providers who are perhaps less aggressively recommending these treatments to Black patients, and also the financial burden that these Black patients experience to start with, as we've seen in the previous slides regarding health insurance coverage and medical debt.
And then another quote by Ma, Agrawal, and Mahal stated that the majority of patients had prostate cancer in their study, and 36% of those received novel hormone therapy. White patients had the highest 2-year novel hormone therapy utilization rate at 27%, followed by Hispanic patients at 25%, and other racial/ethnic groups at 23%. Black patients had the lowest rate of using these new hormone therapies at 20%. And the researchers found that Black men were 24% less likely to receive or be prescribed one of these novel hormonal therapy agents compared to white men. And then so you have to understand how these new treatments, which offer better coverage for prostate cancer, why were they being used less by Black men? And then this disparity could contribute to that increased mortality of prostate cancer in Black men. So the question becomes, what can be done about this issue? And what are some ways we as future physicians can reduce such disparity? Things such as community outreach and education, such as this flyer right here on the right, which shows a health symposium raising awareness for prostate cancer locally here in Augusta, Georgia. Things such as early detection, better representation in healthcare, as well as addressing systemic issues. First, when we think about community outreach and education, we have to realize that education on certain healthcare topics helps reduce stigma. And reduce stigma, patients are more likely to get early screening and detect possible cancers. So things such as putting up flyers in barbershops or meeting with community leaders to host events to spread awareness within the community, to gather people around and just give them education on certain topics such as prostate cancer. And all of these methods would reduce the stigma. And like I said earlier, lead to early detection. And early detection of a slow-growing cancer such as prostate cancer means that it be found at earlier stages and can be treated earlier. Next, a lower accessibility to physicians with similar cultural backgrounds can be a factor to the unwillingness to seek care. And then we know that, people who find physicians with similar backgrounds to them can mesh a little better and they can trust them and receive more timely care because of said trust. And when it comes to prostate cancer and the increased mortality found in Black men, we have to consider the makeup of our healthcare system. And in 2019, Black people made up about 13.4% of the US population. However, only 6.2 of medical school graduates and only 5% of active physicians were Black. If we could find ways to increase these numbers, we could also find ways to increase the access to care of physicians with similar cultural backgrounds and further build that trust. And then if we invest in efforts aimed at increasing the amount of Black medical students, residents, and physicians, it could lead to better outcomes when it comes to prostate cancer. And finally, addressing systemic issues. Earlier, we mentioned the conscious and unconscious bias that could lead to providers pursuing aggressive treatment for certain population of patients compared to others. And if we continue efforts to build trust in the healthcare system among patients and communities, that bridge can be closed, or I'm gonna redo this again.
We can redo this slide.
Yeah, definitely redo this. All right, so next, when it comes to addressing systemic issues, continued efforts to build trust in the healthcare system among patients and communities can go a long way. When it comes to things such as conscious and unconscious bias, being able to fight these biases in healthcare could lead to better quality of care for said patients and better outcomes, especially when it comes to prostate cancer. And to conclude, we have a quote which I believe summarizes the whole sentiment of this presentation. So in conclusion, the best evidence is that racism does not cause prostate cells to become cancers. But once that malignant transformation takes place, the efforts of racism influence the chances the patient will die as a result. Thank you very much for listening to our presentation. We hope you found it very educational and can take something to spread to your friends and family, as well as future colleagues in the healthcare field.
Thank you.